about the Chicagoland Syndemic Advisory Council. We will be recording this. So Ravi, if you would, please set up the
Already
recording.
hit the, yes, I did it.
Excellent. Thank you very much. All right. That's because we're a small group. Let's do a quick going around of who we all are. I'll start. My name is Patrick Stonehouse. I use he, him, his pronouns, but anything with respect is fine by me. I'm Director of Public Health Operations for the Community Health Services Division of the Syndemic Infectious Diseases Bureau of the Chicago Department of Public Health. And I'll pass it along. Popcorn it to Gina.
Great. My name is Gina Lamar Evans. I am the owner and founder of Nephew's Case Management. I'm a case manager, and I go by any respectful pronouns.
Say inside
Oh, I'm sorry. I'm gonna popcorn it to Hassan Adebola.
Good morning, everyone. Nice to be here. My name is Adebola Hassan. I'm the section chief for TB and viral hepatitis in the Illinois Department of Public Health. Oh, I'll popcorn it to Jill.
Morning, everybody. Jill Dispenza, she, her. I run the State of Illinois HIV STD hotline and the HIV resource hub for the Chicago EMA. And I will pass it to Diana.
Good morning, everyone. Diana Beasley, Management Synergistics, Inc., located, of course, here in Chicago. Work with the Department of Public Health, particularly with our various committees. And it is my privilege and my pleasure to see each and every one of you. I will then popcorn it over to Gordon. Gordon.
Hello, good morning, everybody. I'm Gordon Schweigert. Currently, I'm one of the co-founders of a non-for-profit called Equity Alliance Health. I also maintain the current position of Executive Vice President of MedWiz Specialty Pharmacy of Illinois, and been in Chicago-based healthcare for about 30 years, with probably my more notable programs in the past, starting a pharmacy called C&M Pharmacy, which was sold to Walgreens. And who's left? To popcorn two.
Ravi.
I can.
Oh, I guess we could
Please.
take the people off the sides.
Hi, my name is Tremaine Jones, and I'm a supportive housing case manager with Chicago House and Social Service Agency.
Hi, this is Justine. Like Besley, I work with Lurie Children's Hospital, the Ryan White Program Coordinator, and I use she, her pronouns.
Looks like we're down to my CDPH colleagues.
Hi, I'm Ravi Jakula, pronouns he, him. Work as a public health administrator with Syndemic Infection Bureau. Now I'll popcorn to Antonio.
Good morning, everyone. Antonio King, he, him, his, or Mr. King. Public Health Administrator with the Chicago Department of Public Health and the LGBTQ Health and Outreach Liaison. And I'm not on the camera today because I wanted to show off my new city photograph. And I'm going to popcorn it to Tiffany.
Good morning. My name is Tiffany Anderson. I am a public health administrator here at the Chicago Department of Public Health. And I think, I'll popcorn it to Dave because he joined just in time to introduce himself.
You might still be connecting.
That's what I was gonna say. If I know Teams, he's probably still connected.
Antonio, do you think you have a picture up? Because there's nothing there.
You don't see his picture?
No.
None. Oh, maybe external. Can you see my picture?
Nope.
Nope. Dave?
Oh, wow, really?
I know.
see
That's why
anybody's.
when you announced that, I was like,
I can see both of your pictures, Tiffany and Antonio.
I can
well,
see all
that's
of
because
them.
I guess the guest can't see
But can you
Oh,
see the formal official like City of Chicago picture?
No,
'Cause
we
I
only see
can't.
their initials in a circle.
See,
really?
I see the same old pictures y'all always have, which are lovely. But it
Well,
like
actually, my picture's new too. I mean, I've had it a
Yes,
long
that's a
time, but I
current one.
changed it.
Yeah,
Oh.
sorry, Antonio.
Oh, no, I'll rectify that. Don't worry about
Well, Dave,
all right.
when you were logging in, I was popcorning it to you so you can introduce yourself.
Good morning, Dave Kern. I use he, him pronouns, and I'm with CDPH Syndemic Infectious Disease Bureau.
All right. And with that, I'm going to go ahead and share my screen for the presentation we'll be doing this morning. It's a small group, so I'll spend as much time answering questions as necessary. Yeah, we'll just do this. Can y'all see the presentation?
Yes.
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 Excellent. Thank you very much. Okay. So today we will be talking about the Chicagoland Syndemic Advisory Council. Syndemic Advisory Council. So first I want to give an overview of the Syndemic Infectious Diseases Bureau. It is made up of a number of different divisions. Today we will be speaking mostly about the impact and advisory capacity towards Community Health Services Division. But it is important for us to know that there are other elements of the Syndemic Infectious Diseases Bureau. There is our finance and administration team, research, strategy and development, tuberculosis, clinical services, STI clinical services, public health services, which is a collection of services related to syndemic infectious diseases for which the Chicago Department of Public Health is uniquely positioned or authorized to do. So this is surveillance. This is like research projects like Medical Monitoring Project and National HIV Behavioral Surveillance Program, as well as partner services, and elicitation programming. So basically things that we internally do in response to syndemic infectious diseases. Community health services, which we'll be talking a little bit more about, is sort of the opposite, is external stuff. So this is where we work with community partners, delegate agencies, stakeholders. It involves strategy, planning, marketing, funding, of course, but overall, like how we implement with our external partners, the different strategies involved in addressing syndemic infectious diseases in the jurisdiction. And this is the overall public health system. It's a very frequently used image. It shows sort of the complexities of a public health system that involves, sure, CDPH, but also schools, emergency medical services, hospitals, nonprofits, nursing homes, community centers, laboratories, all of these different things that you see here, and probably more, that all come together and create the system. So we are one component of that system, and we do a fair amount of the coordination of it, but the system itself exists because all of these different parts are partnering together to try and address areas of public health concern. So as I mentioned, Community Health Services Division, this is where we partner with delegates and delegate services to external organizations. The big one that we normally spend a lot of time talking about is the HIV services portfolio. And you'll see the three sort of programs beneath that, which we'll talk a little bit more about in a moment. But they are healthcare access, community development, population health, and housing and resource coordination. The HIV services portfolio, which we implemented several years ago at this point, was really based on the idea of a status neutral approach to services, that individuals impacted by HIV services come in through this path based on education, outreach, and such. And they're screened for HIV. And in one direction, if a person is identified as having HIV, then we determine, are they a previously diagnosed individual who's out of care? And then we work to re-engage them. And then they're engaged in HIV care and treatment. This is the goal. This is what we're trying to do, the steps we're trying to take. If the person with HIV is newly diagnosed, then we want to link them to care, and they're in HIV care and treatment. If a person is identified as not having HIV but being vulnerable to HIV, well, then we're going to try and connect them all the way over to PrEP care, our pre-exposure prophylaxis for HIV. So one of the things we determined years ago when we were looking at this is something that individuals had identified, organizations had started doing, and we created sort of the system and structure around it so that it could be the formal, this is how we are doing things, is basically that each of these steps functionally is the same regardless of HIV status. So there's a screening, there's an identification. We determine if this is a person who's been in care before, whether that care is HIV treatment or PrEP care. We either link or re-engage the person with care, and then we try to support them using supportive services to be retained in care, to maintain their adherence to their medication, and in other ways, trying to protect their health. And so we established this is the status neutral path for folks, and around that are all of these other things that help make it work. There's HIV resource coordination, there's marketing and communications, housing opportunities for persons with HIV as well as persons vulnerable to HIV, and community development, which is basically acknowledging that with all the clinical and supportive services, there are still going to be individuals and populations for whom it isn't sufficient because there are systemic and structural barriers getting in the way of their ability to access or fully benefit from those services, those clinical and supportive services. So then these are the programs that fall, these are the individual programs that fall within each of these broader programs that I just described. So you'll see within healthcare access, population-centered health homes, HIV primary care, essential support services, and so on and so on. So these are all like the clinical and supportive services focused on people with HIV as well as people vulnerable to HIV. So we harness them all together and put them together in this path that is status neutral, meaning that, for example, with a population-centered health home, a population-centered health home will be able to provide all the clinical and supportive services for both persons with HIV as well as persons vulnerable to HIV. So in previous structures, it would be you go over here if you're a person with HIV, and you go over here if you're a person vulnerable to HIV. So with this structure, we've made it so that no, to the greatest extent possible, with stretching the dollars and resources that we have, we want you to be able to get those services at the same place, regardless of your HIV status. Then breaking down housing and resource coordination with the various kinds of housing opportunities for persons with HIV, housing opportunities for persons vulnerable to HIV, and the HIV-STI Resource Hub. And then lastly, community development, which is again looking at these structural and systemic barriers. So community development, the program is by, of, and for structural interventions, looking at what are the from the prioritized population. So from the perspective of a collection of, let's say, Black transgender women, what is the prioritized systemic or structural barrier that they are experiencing? And then they get to work together to come up with, all right, well, what is the structural or systemic intervention we want to put into place? And then you implement it and then you evaluate it. And that's been going on for 4 years now. Community responsive screening and linkage to wraparound services is similar. It's population specific, where incorporating screening for syndemic infectious diseases as well as resource coordination into existing program that is by, of, and for prioritized populations. Services for people who use drugs, which is sort of comprehensive harm reduction services, syringe exchange program, opioid overdose prevention, screening for HIV, viral hepatitis, and a range of other services that are incorporated specifically for focusing on persons who use drugs. The Community Health Response Corps, which is an element of our effort, which is looking at how do we create a broad, widespread, resourced and networked collection of individuals who work in community areas within the city of Chicago that are deeply impacted by chronic disease, as well as historically under-resourced, to give them the tools to become really effective public health resources for their neighbors, their family members, their loved ones. And then innovative sponsorships, which is small funding opportunities that we put out generally to non-contracted organizations and partners to put on really cool events, services, activities focusing on our priority populations. So these are all the programs. With the Syndemic Advisory Council, it's going to be focusing on the healthcare access. So this top program here, the clinical and supportive services involved in it. But the reason I'm going over all of these is that historically, in the previous planning councils, the council was involved in sort of working with CDPH to help craft what these full collections of services can be. And that was a monumental effort that took years and years to do. Then when we look at now I'm putting these initiatives that the health department has got going on top of those programs. So looking at the data from all of the programs that I just discussed in these different program areas, making sure it's clean, making sure it's accurate, looking at it, trying to identify any trends, and of course, reporting it out to both the organizations that are submitting the data to us, as well as to our federal funders, stakeholders, elected leaders, and such. Evaluation is the component that goes across all of these programs. Fundamentally, the evaluation is to ask the question of what impact are these services having toward ending the HIV epidemic in the jurisdiction. And there's a lot of process evaluation as well as outcome evaluation involved. But fundamentally, that's the question that is being asked with the evaluation programming. Is this working towards ending the HIV epidemic? And is it working towards ending the HIV epidemic for the jurisdiction as well as for our priority populations? Equity hits on that point again with focusing on those populations most deeply impacted by HIV, as well as social determinants of health and syndemic infectious disease, where in looking at our data, in looking at the workforce, and looking at our programming, ensuring that we're asking deep, probing questions to get at the function and outcomes of the services that are being provided and the activities we're engaging in. So it's you take the data, you take the evaluation, and then you dive in more and you continue asking questions, focusing in on priority populations and those populations that are deeply impacted to ask more and more questions, get more and more detailed so that we can create more and more focused programming, whether that's large scale programming or sort of minor shifts that may need to be taken in different settings. And then lastly is planning. And planning, and this is a fun one because I like it. This is another image of this idea of planning. So historically, or prior to now, we always thought of planning, HIV planning specifically, as residing in a single place. What previously was the Chicago Area HIV Services Council, or CAHISC, and that was like the planning council. So if you want to get involved in strategic planning for the city of Chicago, that's the place you go. But in reality, there are a number of different paths to influence our strategy within community health services and beyond to the rest of the services that are being conducted within Syndemic Infectious Diseases Bureau. So we are going to be talking about, we're here today to talk about the Chicagoland Syndemic Advisory Council, but it is important for folks to understand that there's a lot of other things that go into this. There is ongoing delegate agency monitoring. There is the HOPWA Equity Project, which we are one of 7 jurisdictions that is looking at our housing opportunities for persons with HIV programming with a very focused equity lens from the point of writing a funding opportunity all the way through looking at the health outcomes of individuals who are receiving services. This is going to be very shortly, like hopefully in the next week or so, we're going to be releasing sort of a data collection for individuals who are interested in participating in the HOPWA Equity Project. It's not a membership, it's not an advisory council, it's a working group more that's really focused on looking at equity within housing opportunities for persons with HIV. Next is Direct Service Providers Forum, which is a thing we did back in the fall, which we're going to be launching again fairly soon. And this is really about pulling together into the specific individuals who are conducting HIV screening sessions, the specific individuals who are doing PrEP navigation, and hopefully we'll be bringing in folks who are themselves performing case management. So this isn't about supervisors or managers or directors. This is about the person who is doing the screening or the navigation or the case management. And it's really about workforce development. It's about skill sharing. It's about best practices. It's about creating a stronger network between all of the different organizations and individuals who are providing that direct service. And on the CDPH side, it's about wanting to develop another path through which we can find out what's going on quickly. So rather than waiting on monthly or quarterly reports, we will have the opportunity to hear from people who are conducting those services about what they were experiencing last week and possibly make some adjustments based on that. Next is the Chicagoland LGBTQ Plus Health Forum, which meets every Friday morning. And that's really just an awesome group of folks who come together to strategize what we're going to do to try and respond to areas of concern, regarding LGBTQ plus health, but also to bolster positive elements of the health and well-being of Chicago's LGBTQ plus populations. There's ongoing clinical quality management, which we work with across all of our delegate agencies that are providing clinical care to identify policies, or not so much policies, but like procedural or structural issues that they're exploring. Like maybe this change in our clinical flow would address this particular area of public health concern that we're seeing. Population accountability spaces is something that we're building up right now, which are going to be by, of, and for forums, basically for priority populations, which at the beginning are going to be focusing on Black, gay, bisexual, and other same gender loving men, and Hispanic or Latino, gay, bisexual, and other same gender loving men, to really bring together members of those populations to talk about what they're experiencing, to identify areas of concern, as well as, again, to identify areas of positivity that can be amplified as much as possible. And again, this is the intention of that group, is to create an advocacy space, an accountability space within that population that then has the ability to impact services, programming, strategies, marketing next week, not next year, not next month, but as quickly as we possibly can. Delegate and subcontractor manager meetings. This is a thing that's going to be coming up soon. So similar to the direct service provider forum, which is about the individuals providing direct services, this is about managers and supervisors and such. And then, of course, the ongoing evaluation. And this is not meant to be a comprehensive list of all the paths into planning, but just as an example, like there are a lot of different things going on. And the Chicagoland Syndemic Advisory Council is an incredibly important one of those. And when we talk about syndemic planning, it just created this simple illustration of what we're talking about. HIV, STI, viral hepatitis, tuberculosis, Mpox, they all fit together and they all impact one another. They're connected by way of population, route of transmission, mode of treatment, or prevention strategy. And the impact that we are able to have on one of these will likely have impacts on the others. And so the idea is that we're able to leverage the resources we have in each of these spaces to try and have positive desired impacts on ending the rest of the syndemic infectious diseases of concern. So this is the Advisory Council. So again, we're looking specifically at healthcare access programming. And the Advisory Council is a federally required thing that we have to have, and we want to have, because we receive Ryan White Part A and Minority AIDS Initiative funding for care and support services. The group looks at service delivery data, looks at surveillance data, looks at other funding sources that are coming into the jurisdiction, and makes the determination of where are the gaps, where are the needs, what do we need to do in terms of adjusting the funding specifically of programming going in, and then allocating percentages of the funds that come to the area to different service categories that go into making up these healthcare access programs. And then last thing I just wanted to touch on, that as this is a mandated council, and there are mandates of how this council is structured. So it is mandatory that 33% of the people on the council are people with HIV who do not work for an organization that provides Ryan White Part A services. And it must reflect the epidemic in the jurisdiction. And so that means looking at racial identity, ethnic identity, gender identity, geography. And geography is important because, folks do have a tendency to focus in specifically on Chicago, but we are looking at the Chicago eligible metropolitan area, which includes Cook County, DeKalb, DuPage, Grundy, Kane, Kendall, Lake, McHenry, and Will. And in addition to that, there are mandated seats. So the Health Resources Services Administration, which is the federal body that issues Ryan White funding, mandates that this council include the following seats. So healthcare provider, pharmacy provider, community-based or social service provider, housing services or services for people experiencing homelessness, mental health, substance use, harm reduction, planning agency for hospital or healthcare system, non-elected community leaders, county and local government, Illinois state government, and recipients of Ryan White Part C and D, and recipients of direct CDC funding for HIV prevention services, as well as individuals representing persons who are currently or formerly incarcerated. That's the overall structure. And that was a long presentation, but now we're getting to the points of the ability for us to have direct questions and answers right now. After this presentation, of course, there is going to be another webinar a week from today that folks are more than welcome to join if they have more questions, but you can also send emails to my colleague Ravi, whom you met earlier, who will be receiving all of the questions and concerns as well as the applications for the council and cycling around through all of us to provide appropriate answers for everyone. And that is the presentation. Any questions from anyone?
Good morning, Patrick. How are you? I do have a question.
Hey, Vance, how are you?
Hi, I'm a great thing. Thanks for asking. Who reviews, like, what is that the process for reviewing the application, and who makes the determination?
So we have a smallish collection of external partners who are experienced with previous community planning efforts who are going to be reviewing applications, as well as some CDPH involvement. But really, we're going to be focusing on having our external partners who have done this kind of work before take a look at it. And the reason we're going that route is because we want to have folks who know who know the Ryan White process, because that is the foundation of our activities with priority setting and resource allocations and such, um, but also are keenly aware that you can't only have folks who are intimately familiar with the former planning processes, that you do need to have you need to bring in folks, you need to bring in new voices, you need to bring in representative voices. um, so we have a small group who's going to be doing that, and the way it's going to work is looking at all the responses to the application. So you look at the responses in terms of demographics, representation, geography, that list of mandated seats that we just laid out. And so we're looking at all of those things, just trying to see like, okay, we're required, we need to meet this representation and have these mandated seats, as well as look at the responses to the essay questions that are in there, and try to determine, all right, how are we going to make this work in a well-rounded, thoughtful, and provocative way?
So the follow-up question to that is, and I heard you. The follow-up question to that is, does this group of people, do they reflect or represent how diverse the council would be? Because, so I guess what I'm asking as a minority in my population is, kind of like gay Black men, we are kind of like priority population. I just think, is it going to be like a group of white men that's going to make these decisions, or like, so I'm just trying to be very specific on, because I'm trying to understand like what prevents people from saying, okay, we don't, or if they know people in the community that are particularly effective in helping to accomplish the task of, like, do they have knowledge base, or are they just, what particularly are they using to decide if someone is a yes or a no?
So I'll actually, Dave, I'll ask you if you're on. Are we able to disclose like the specific individuals who are doing it? It's not a group of white men. I'll just say
Okay.
that. So it's a reflection of a range of races, ethnicities, genders, HIV status, and it is folks who are, again, like, it's folks who know this work, not just in terms of like the planning council and the Ryan White activities, but like how it actually gets played out, how folks do the work that is funded with Ryan White Part A, Minority AIDS Initiative, and underfunding sources. So folks who have a good range of connections across the jurisdiction and involvement in a number of different areas. Dave, anything you want to add to that?
No, I think that's right. I think the important point is the review group will be reflective of the epidemic, and it's still in being composed. So we can't really say who's going to be on it right now. But yeah, it will reflect the epidemic, as well as everything that Patrick mentioned around experience and relationships.
Thank you.
Yeah, thank you.
I had a question about the mandated seats. At least historically, in Cahisk and other planning groups, the mandated seat people often weren't there because they're mandated and they have other things. It's not but I think it didn't it was not helpful if they were chosen for their input and because of where they sit, and then they weren't there. Is there a way to make them come?
Yeah, I gotcha. So here's something that's and this is in the application, which reminding myself, there's going to be a red cap version of that application coming out like today. So if folks have like printed up the PDF version and like this is ridiculous, like patience please, there's going to be a survey, an online survey that's going to come out later on today that'll allow you to do it. If you've already submitted your application, you're good. You don't have to worry about it. So in that application, we talk about these mandated seats, and there's another part where we talk about how, you know, the organizations that are carrying out the work are actually rarely discussed within the planning council. We speak in terms of like services, but not an organization. And part of that is that membership to the council belongs to the individual, not to the organization that they work for or work with. And so if, I am a member of the council and I leave Chicago Department of Public Health, I would be able to keep my membership regardless of where I work. Where that doesn't apply is to the mandated seats, right? So mandated seats are, for example, for the state of Illinois, we need to have someone from the state of Illinois who's participating in this council. If the person who is assigned to represent the state of Illinois on the council doesn't show up, we do have the ability, and we have done so in the past, to reach out to the state of Illinois and be like, hey, old dude's not showing up. Can we address this? Because we need to have that person present and participating. And if it's not that person, like, fine, we can discuss is there a more appropriate person, however you want to do it. But it is a sort of it is a requirement, and we can and do reach out to those institutions to say, hey, we need someone to come in here for this. Antonio, I saw your hand up.
Yes, just kind of going back to the selection process and kind of, well, not caveat off of Vance's question. Can you mentioned also when you said jurisdiction across the jurisdiction, can you also clarify what CDPH's role would be in that? Because you mentioned CDPH. Yeah, you said the selection process, they'll go through the applications and see, you said something about CDPH. That's why I was just clarifying what CDPH's role is in the selection process, just for clarity.
Sure. So CDPH's primary role is making sure that we're going to meet as many of the requirements as possible. So handing these applications over to the reviewers, and we need to work with them to make sure that that it is representative of the epidemic in the jurisdiction, that it is a range of geography that is reflective of the jurisdiction, that we're hitting all the mandated seats. Like our involvement is really to make sure that when all is said and done, that this council meets all of the federal requirements and meets all of like the local needs and wants of it.
Thank you. Right. I just want to make sure it's understood.
Yep. Any other questions?
How many, maybe it said it somewhere, but how many people are on this?
It does not say. We're looking for a manageable number. Thinking 20 would be sort of an ideal. In previous planning councils, when we got upwards of like 50, I think, Diana, correct me, I think we were at 48 at one point. It was so large, it was almost unmanageable. And it was really difficult to get things done. And so we want to have a smaller group of members, so it is a more manageable effort. Also, we're focusing in specifically on healthcare access. And the previous planning council looked at HIV care, HIV prevention, and HOPWA. It also looked at the healthcare access and housing and resource coordination and community development. And this is really focusing in on that healthcare access element for the purpose of focusing in on like the clinical and supportive services in the jurisdiction and having a direct connection to the mandate of the group, which is Ryan White Services. and Ryan White funding allocation. So, for example, while we had a housing and resource coordination committee within the previous planning council, it didn't really it didn't have a federal mandate to do stuff, so it could make recommendations, and we're like, yeah, all right, that sounds cool. Let's try to do it. Versus with healthcare access, like this is the recommendation, and you have to do it. And so it sort of cuts through some of the fog of like, no, this is what you do. This is what this council does. It focuses in. It also allows for an opportunity to do a stronger incorporation of the clinical and supportive services regarding syndemic infectious disease. So not just focusing on HIV, but looking at STIs, viral hepatitis, tuberculosis, and Mpox, and how we incorporate clinical and supportive services relating to those into the healthcare access programs. And lastly, what it does is it allows for a bit of like a diversification of what folks are involved in. So there is, again, there's this advisory council, but there are also all those other paths that are built to focus in on different areas of our work, and not wanting to sort of confuse or muddle the situation. So this is healthcare access. This one's about HOPWA. This one's about direct service providers. This one's about population experiences and such. So wanting to keep it small-ish, still 20 people-ish, so we can focus in on our efforts.
So I have a couple of questions. First
By all
one,
means.
which one are we using, STIs or STDs? Tell me what we're really using there. Anyway, because I saw your presentation said STIs, and I was just like, are we going back to STDs? What's happening here?
STIs.
Right, we're sticking with STIs. And then I did see you talking about PrEP, but what I didn't see, and don't know whether or not we have any numbers on, are we using PEP? I mean, who's using PEP?
Yeah, PEP is absolutely it's a key component of the prevention strategy in the clinical supportive services. So a lot of organizations, and we can at another point, Gina, I would love to do like some presentations of the programmatic data related to PrEP that has taken place within healthcare access. But a lot of folks, a lot of organizations at least use so PEP, for those of you who don't know, is post-exposure prophylaxis. Medications that can be taken after an individual has had a potential exposure to HIV to prevent HIV from taking hold and infecting the individual. A lot of organizations use PEP as a path into pre-exposure prophylaxis. So a person comes in, gets PEP, and like, okay, let's talk about ongoing for preventative purposes. So yeah, it's absolutely a thing. And just on that note, so, you know, because the Syndemic Advisory Council, its focus, its product, like what it does is looking at Ryan White Part A and Minority AIDS Initiative funding, that those dollars are mandated to go to clinical and supportive services for persons with HIV, right? But as we discussed, this is a status neutral program. And so there is, as much as possible, a corresponding resources that come into the healthcare access program to ensure that these services are not just for persons with HIV, but also for persons vulnerable to HIV. And so what that looks like is like, here's your funding for, let's say, outpatient ambulatory services for persons with HIV, and here's a corresponding amount that comes from another funding source that allows you to provide the same services for persons who are vulnerable to HIV, because by way of being vulnerable to HIV, they are not eligible to receive the Ryan White Part A services because that's restricted just to people with HIV.
That seems, you know, I'm very, very supportive of the status neutral and know how incredibly important that has been. But as this council seems to be focusing, unlike in the past, like really like healthcare access, Ryan White, Minority AIDS Initiative, it almost seems like the status neutral part is pulling it away from that focus. You know, because it seems like this has been super focused so that something can really happen, like really PSRA happens, right? But then I just wonder how that status neutral part fits in as you're focusing completely on PSRA for people living with.
Right. So for those of you who don't know, PSRA is priority setting and resource allocation, which is the process the council goes through of prioritizing each of the different service categories from Ryan White. And then the resource allocation is when you say what percentage of the award that the EMA gets goes to which of the different service categories. So yeah, it's a good point, Jill. So the way it works is, and we'll be making adjustments because the council, as it is seated, needs to be involved in determining like the full details of the process. But the way we've done it in the past is looking at all of the different resources that are coming in that are available to these collections of services, and knowing that because we want to maintain a status neutral, that we can't just speak to the Ryan White Part A allocation. It becomes our job, primarily within CDPH, to come in and present like, all right, in order for this to be balanced, everybody needs to be aware that there needs to be a corresponding funding source that allows for the service to be provided to others. So you're not just talking about Ryan White Part A. You are talking with us about like, what we know we have available that goes in to correspond with that. So that's how the planning maintains that status neutral approach. And it is not council does Ryan White Part A and minority initiatives, and then CDPH goes into the back room and is like, okay, we're gonna. No, it's like, all right, here's how we make this happen, and everybody cool on this council with how this is going to be structured within the confines of all the different funding sources that we have coming in. But is everybody cool that this is how this is all going to be braided together?
Thank you.
Yeah, thank you. And sort of on that, like it makes me, like you were saying, Jill, like the focus on healthcare access and Ryan White Part A. It is important for us to not forget that there is the other side of the status neutral programming, but it's also important for us to remember the syndemic infectious disease part of it. So bringing in subject matter experts and talking about funding that is available for clinical and supportive services related to viral hepatitis, tuberculosis, Mpox, and STIs, like all of that needs to get incorporated in so that the healthcare access programming is addressing as much as possible the collection of syndemic infectious diseases.
I just want to add that we're trying to make it well-rounded, which is really critical and important to getting all of the work done under this particular system. So attempting to deal with that well-roundedness is important.
Thank you. Sorry. I'm yakking on to myself. One of the things I read in the application was that it's not an advocacy group, because definitely the last group was kind of that. Are people, like, when that happens, because it will, what's the system to either say, put it in a parking lot, or please speak to Service Providers Council or something for that advocacy? Like, what is the, so it stays a little bit closer to its original intent?
Diana, I would actually welcome your contribution on this as the facilitator of these years of planning councils, how you handle such situations. Because you're right, it happens all the time. And yeah.
It does happen all the time, and we're attempting to, of course, keep it limited.
Because people may not even understand they're advocating.
Right? Exactly. Exactly.
It's going to be a learning curve.
and it will lend itself to point out that this is advocacy versus the other aspect that we're after. We want to use various techniques, which is why the facilitation comes into play, to, yes, use the parking lot, or yes, your point well taken on this, it needs to go here. and putting it into another place, if that makes sense. But also attempting to get the best out of whatever that that issue is that is relevant to what the planning body is doing. We want to always maintain that level of openness also. But using various techniques, understanding that, and helping the group understand where did we cross the line? You know, are we on the crosswalk or are we in the middle of the street here? So we want to be able to make sure that occurs.
And I see your hand, Vans. I'll get to you in 1 second. I just want to share real quick again this slide. Is it showing?
Yes.
Yes. Okay. So it is inevitable that folks are gonna come to Chicagoland Syndemic Advisory Council and want to advocate, and it's wonderful. As a reminder, these are open meetings, so while there's going to be formal membership, there's also going to be, like, you know, as I mentioned earlier, Cahisk, the previous planning council, had like 48 members. It often had like 48 other people who showed up, so like we were pushing 100 folks at every single meeting, and that's awesome. It's wonderful. The concern is that planning council doesn't really have a mechanism of addressing the advocacy issues. And so it's like when the planning council, what it does is it does the priority setting and resource allocation, and it does that for next year, right? So advocacy almost inherently is about something that needs to happen now. And that's just not what the council does. The council looks at next year. And so by showing this slide again, I'm intentionally bringing up, like, some of these other things are about right now, right? And so in previous years, we weren't as clear, at least internally or externally, I think, that if someone comes to the council and they want to talk about something that needs to be done right now, we were like, yeah, there's another space for that. But now with this structure, we're like, and it's this space. Let me connect you to the person who you need to talk to try and influence things now. It's this space. It's this space. Like, there are direct places where we can connect folks to that are ongoing activities. Most of them, some of them need to be stood up, but there are places where, like, go here. It is for exactly what you're talking about, because it's not that, and I want to just be very clear, there's zero interest in stopping accountability or stopping advocacy. It's really about, like, let's put it where it's going to, let's like support it in getting to the place where it's going to make the most difference, because the planning council doesn't have the ability to act on it. Vance, go ahead, please.
Just a small question, just for clarity. Is there a parliamentary procedure used with these council meetings, or is there automatic assumed officers? I know you said Diana was she read. Is there like a democratic process to, you know, because when you said when Jill spoke to how to, you know, prevent advocacy, I was just thinking, well, is there a parliamentary procedure where there's like this type of order that people could rise to points of interest, or so how does that particularly work?
Diana, go ahead.
No, I was just going to say, yes, we do use parliamentary procedure, but we also use a process by which we want to garner information, because sometimes parliamentary procedure can lead down other roads. But but we want to have, we will have, and have had a system in place and a opportunity for people to explore and understand why maybe they need to go to another group to get the answer that they want. And then we can move into, okay, how do we can continue to work the process? And that's where that parliamentary procedure comes in. We do some consensus building along the way too. So it's not just the nays have it or the yays have it, or that type of thing. But do know, yes, we do use parliamentary procedure to put things in an orderly, or as orderly as we can with that particular system, and hear people. I think that's the other piece of this, being able to hear what people are saying, and now having a place to direct them, to know where to carry their message or what they're interested in. So Hopper may be what you need if you're housing, where that's the group that you can get to hear from rather quickly, and they can manage what you are looking for them to manage for you.
Yes, I appreciate that. I asked some questions because in hearing about the old keys, just trying to figure out what particular, importance or priority or authority or, do the council members have? Like, what is it, understanding, what is their responsibility or duties outside of just coming together and making decisions, but can we be disbanded? Hey guys, get out. Or what is the what keeps us glued there even when we disagree on things, or just asking those type of questions. Yeah,
I think being able, I'm sorry.
No, please, Diana, go ahead.
I just want to say, Vance, I appreciate your question. I think being able to understand where people are going, what they're trying to say, and then and now we can direct them to other entities, where before the planning council was the beginning and the ending, and that's it. And I know, let's go to the planning council, because that's what was available. We now have other areas by which people can go, and also methodologies by which people, will adhere to, such as parliamentary procedure and or a consensus type of method for this given situation.
Thank you.
So a couple of things wanted to add, because Vance, you alluded to I think officers or so there's basically there's one fundamentally mandated position within the council, and that's the community co-chair. The council will have the ability to determine, all right, what else? What other officers, positions, subcommittees, how does the council want to do it? And we we didn't think it would be appropriate for CDPH to this is the structure. Nah, yeah, that's not how this is going to work. We'll bring together the group. That group will then determine how it is structured. Next, wanted to point out in the application, there's a please save the date for Wednesday, April 26th, and that's going to be the orientation to the council. And Diana does an incredible job of orienting to what are the functions, what are the roles, how does this work, what are Robert's rules of orders and how does it work, an overview of priority setting resource allocation and parliamentary procedures and all that kind of stuff. And she also does a really solid job of reinforcing and reminding us, I'm saying us because she reminds me a fair amount of these things moving forward, in our meeting, just want to remind you, Patrick, this is how Robert's rules of order works. And I'm right, thank you, because I don't know Robert, I don't like Robert, but I get it, it's important, let's do it, it's fine.
Who is Robert?
Abadullah, you have your hand up.
Yeah, Adebola. Oh, thank you for this session. I think it has really helped me to understand what some of the expectations are. And when this application was shared with me, it seemed like this was something really good, especially because we're also working on the viral hepatitis coalition at the state level. But I did go ahead to share with my staff. So my question essentially is, since you've elaborated that the focus this time around is about access to care, I was wondering, at the state level, is this round of application really a session where you would want the participation of IDPH? When I heard access, I thought more about Medicaid. I thought more about other agencies that are, instituted to help with access, because our focus is, yes, guidance. Our focus is also kind of shared outcomes and looking at partnerships to help with access, help some of the community participation. But based on some of the explanations you've made, I just want more insight into some of the expectations at the state level, so that at the level as well, maybe this round might not be the best for a lot of persons, because I shared with my staff already and encouraged them to participate. And it might just not be probably the best of times for them to put in an application if the expectations are focused on access and the fact that it's they're going to fall under the category of mandated seats, and the numbers, I guess, that would be allowable for that will be very limited. I just want more clarity, and helps me to manage the expectation of staff that I've also encouraged to apply.
Thank you so much for that. So usually, so I'm gonna go ahead and say, like, I would love to have someone from the state coming in talking about access in a broader sense and bringing knowledge of Medicaid systems and that range of activities. It is usually, it's like someone from, the HIV section, which is like, great, we know those folks, cool. But I would not be at all mad at the idea of the IDPH representative not being from that branch. Just my thought. So a couple of things. So we are focusing in on this healthcare access. I think I would argue that it would probably be useful for an individual at IDPH who isn't intimately familiar with the HIV services to get involved earlier rather than later to understand the processes. Because what we've seen before is, like, if you come in later on and, like, you want to talk about, I'll throw out tuberculosis, it's important for you to understand what our priority setting resource allocation process already looks like and does. And so it could be a really useful function to bring the expertise related to TB or viral hepatitis or one of the other syndemic infectious diseases and get to know that process that is the priority setting and resource allocation, needs assessment, and gaps analysis, so that you can see, like, all right, how, like, and actually inform the process of how we incorporate syndemic infectious diseases. The other thing I want to throw out is that, membership is one component of it. But again, this is an open meeting, and meaning that anyone can attend. So while there may be, like, one formal seat representing the state of Illinois, you're going to have, like, 10, 15 people show up to meetings to participate and ask questions and learn. And that's full body meetings. It's also, like, generally subcommittee meetings, if we have any of those, are also open to folks who want to participate, just because it's an area of interest and to try and influence and get involved in the way we're doing the work.
Thank you. I think that's very helpful.
Thank you.
You know, if they're going to have in Cahisk, they used to have, like, backup people. I forget what we called it. The people who would move in that were coming to meetings and, participating, and then could move in if somebody rolled off.
Alternates. And
oh, that's it.
But we're not sure about that, because we're in the process of, getting the membership. The membership will then say where we're going and what have you. But at one point, yes, we did have alternates, and alternates would then, should someone leave their seat or what have you, alternates would move into that. But that was then. I have no idea what it would be.
We'll see what the applications tell us.
Yes. Jill, you've been around a while. My, I haven't heard the word alternate in a long time.
Diana just outed me as old.
That's exactly what I heard. No, I didn't. No, but it does make sense, though, to have people who have been around for a while. But I also think it's good to have new people who ask different questions.
It is. So couple things about that. Like, it is always useful to have new perspectives get involved and to ask questions of our processes as well as of the decisions. So we can look at the needs assessment, the gaps analysis, the priority setting and resource allocations in different ways. They're like things that we need to do that we're federally mandated to do, but the how of it, uh, as with anything that is a requirement, we are capable of falling into ruts and just doing the thing that we did last time. And it is very helpful to have new perspectives come in to ask questions and offer alternatives to that. I also want to throw out that, and I can say this from personal experience, like Kahiska is a great, or I'm sorry, not Kahiska anymore. Uh, the advisory council, this function is a great space for people to inform our processes and our outcomes. It is also a pretty awesome way of learning about those processes and outcomes. So personal experience, I think I was an alternate for the membership committee back when Cahis, the previous planning council, first started, and I was working at Heartland Alliance, I think. Um, and I learned so much from that. I got like networked with folks, introduced to new ideas in programming and service delivery, like understood the processes in a way that I had never done before. And I think I would not have gotten the job as director of HIV prevention with the Chicago Department of Public Health if it were not for the everything that I learned and all the people I met in that planning council. So it's a both, right? It's, yeah, we want folks who have done this before and know how to do it, and also then what that means is like how to cut corners in an appropriate and effective and equitable way, as well as folks who are like, all right, I don't know what any of this stuff means. Like, cool, you got the passion, you got the connections, you got the representation, you got the desire. Like, all right, let's make this happen.
The quiet group.
So I will add, because it's a quiet group, we got 25 minutes left. I mean, also, like, we're done, it's all good. Please consider, if you are considering applying for membership to the Chicagoland Syndemic Advisory Council, of course, I would love to have a bunch of folks apply, but also consider like sharing that application and anything that you've heard in this conversation with others who may not have heard about it. So like, we sent the application out to like all of our delegate agencies, community partners, stakeholders, and part of it is like, yeah, you, but also whom else? Who do you know? Recipients of services, colleagues who you think just would be awesome at this, people with HIV, people vulnerable to HIV, people experience like, if there are folks you know who you think would really contribute and get something out of this process, please share anything and everything that's been discussed here today, uh, and continue to ask questions on their behalf, or like connect them directly to Ravi in particular related to this. Like, I would love if, the majority of the applications that came in were folks I didn't know. I think that would be awesome. Antonio, I saw your hand go up for a moment.
Well, I took it back down. But yeah, I was just gonna we sent the notice out to various organizations, but also a lot of community members. And I would like to encourage everyone, um, those individuals who have questions, concerns about the process, those individuals who we know are impacted with HIV and living with HIV and AIDS, though those individuals should definitely apply and be here. Also, I wanted to reiterate for those who may or may not know, because it didn't really come up, those applications and that status is not known to the general body. It's only known to the selection committee. So if they are HIV impacted and they want to apply, CDPH or Jill or no one else who's not on the review panel or reviewing those applications will be privy to that. So it's important that the community, Gina, Vance, that you guys get people out to apply. We don't want the same old, same old. We want some new faces, younger people as well. We need their input. We need their perspective. those individuals who are not working with community-based organizations or who are just part of the community who we see on a regular basis who have issues and concerns and always, there's some certain people always asking us questions about resources. Those are the kind of people we also want who could benefit from serving on an advisory board or just even attending these meetings.
Are you going to have limitations on, I mean, it's a smaller group, so I don't really necessarily see this happening, but I know like with IHPSI for the state, you could only have at most 2 people from an organization. And I know this is to the individual, and that was also to the individual, but they still put limitations on. So it didn't become like Center in Halstead has 5 people, you know.
Yeah, thank you. That did come up recently in some conversations. I think that you were part of those conversations, Jill. At this point, we haven't put that into place. It's going to be like it's something that we will look at. That will be like part of the reviewing. 'Cause to your point, like we don't want, like if it's 20 people, we don't want 15 people from AIDS Foundation in Chicago. We don't want 15 people from Chicago Department of Public Health. We don't want it needs to be balance and representation across a number of different organizations and individuals not aligned with organizations. So it'll be part of like as the applications are being reviewed to look at like the full body of the group to, all right, are there too many folks from any given organization, and try to figure out the best way of adjusting that. The council will be able to make the determination when it creates its bylaws if there's going to be a formal restriction in that regard. The council will be able to say no more than X number of people from an organization at any one given time.
Well, this seems fun. Um, yes, I thank you, Antonio, for passing that. I do know some very articulate young, people from the community that I think that would be interested, and I think I might be interested in that, what is it, ex-convict or recently released or returning citizen part? What was that? Yeah,
Returning
so
citizen.
return to citizen. Yeah, and then they have a lot of titles for that. So yeah, thank you for that. And I will get on that. I just wanted to be able to ask some questions and understand processes, and more importantly, structure, because I think that very particularly people just want to know that their vote, they will be heard, they will be seen, and kind of like will be over talked or undervalued because they don't have. Because I don't have any, like, being new. I don't have any new to this field. I don't have as much understanding of processes with Ryan White and things like that. So there's definitely going to be an understanding and learning curve, especially if you're asking for newer people, and that just making sure that if we bring newer people, that people have patience and understanding and a willingness to even work with them to understand outside of the council, and just to be So that's what I'm invested in, if that is what the goal for it is.
It absolutely is. And one thing we've done before, we've tried at least, right, Diane, is like mentoring. We've done that. We've tried that before. It was like sometimes it worked, sometimes it didn't. But if there is someone or a collection of folks who are newer to this, who have like, or because sometimes it's like it can be an intimidating thing, right? Like here's a bunch of folks who's talking about a bunch of things. They're doing it really fast. They're using a lot of acronyms. It's about it. Like it can get overwhelming. I know. Again, it was for me when I started with the council back when it was Cahisk. I was like, damn, it can be very helpful to have some folks who have been identified and who are willing to be like, you can take me aside in the hallway afterwards, ask me whatever questions you want. I'll happily do it. And there have been folks who have done that. And some of the folks I know who did it before were like, it was like a mixture of like half talking about process within the planning council and half talking about like, how do we take this out of the planning council and get it to the folks whom we know, like, in our lives. And so really like working with each other as peers, like what's the best way for me to take this information and relay it to my lover or to my brother or my sister or my neighbor or whomever. And that can be a really cool thing. It needs to be set up, but again, we'll make that determination based on what the council wants. And if they want us to try and set up some kind of a mentor-ish thing, like I'm down.
I do have, I'm sorry, a quick question about the meetings. I do see there's one on the 26th and then Wednesday, May 31st, that's open to everyone. So will they usually be Wednesdays? Will they be, do we set that or is that pretty much set already?
The council gets to set that. That
Okay.
we're doing that largely because you know, if we were going to be selecting a date for folks, for council members whom we don't know yet, uh, like
Good.
we're going to be, there's a moving target. There is no target, right? We're just like making it up. And so what we decided to do was fall back on what Cahisk did. So Cahisk met the last Wednesday of every month. And so for some folks, that's still like, oh, that's when Cahisk is. Cool. I can incorporate that in. But it's not something that we're wedded to moving forward. As far as I'm concerned, like that can be a determination of that first full body meeting at the end of May is like, when do we actually want to do this? And that's not just day of the week. That can also be time of day. So we can make it available to folks who have different schedules. It is the council's decision.
And then will the council be deciding whether or not we're in person or will this still be virtual?
In person.
Okay.
But the council gets to discuss how that plays out. So for example, back in Cahiskin pre-COVID pandemic times, like it was very, very strongly like basically you're not a present participant in the council if you're calling in. A lot of stuff's changed. So council gets to make that determination. But we wanted to set up at the very beginning, at the very least, these are in person, do it that way, and then we can make the adjustments we need to make.
Because we may find ourselves doing both, some type of hybrid, who knows? But it's up to the council.
I was thinking that only because as we're asking for all these counties with Grundy, Kane, I was looking at all of my, my clients who could possibly attend and who's doing what. And so that just makes a difference if we're, if we have the ability to do hybrid or do they need to come into the city?
Yeah, so I mean, again, the council gets to make this determination, and our job as the health department is to try and facilitate it. But one thing that we've seen from like IHPSI, which is the state's planning council, is that there can be like regional coordination. So not necessarily like you're sitting in your home participating, but maybe you go to meet up with everybody else who's participating in Grundy County at a shared office space, and you can all be in a room together watching this on a screen, like that kind of thing, so that there is some like coordination. But we'll figure that stuff out together. As with many things, we will figure it out together. All right. Anybody want 13 minutes back of your day?
Please.
Please.
All right. Thank you all very much for your interest, for who you are and what you do. And yeah, please, again, feel free to send further questions to Ravi. His email is on the application, and also keep your eyes open for the REDCap version of the application, which should be coming out later on today. And thank you very, very much. Have lovely days, everyone.
Bye.
Bye. Bye.
I know.